Hey everyone, Dr. David Clark. Today we'll be walking through another real-life case study from my office. Today we're talking about a 40-year-old man who has Meniere's disease. So he's having, of course, these rotational vertigo episodes that are debilitating and terrible, and having tinnitus as well and some hearing loss. So let's just jump into this and start talking about how I go through cases such as this. So he's having these random episodes of rotational vertigo, and of course that's the characteristic thing that you see with Meniere's disease. And the most recent one was a few weeks before he consulted with me. Right ear is the primary problem, and he's having hearing loss so bad that he is wearing a hearing aid to substitute for the hearing loss, which is a good idea. Just so you know that hearing loss is generally pretty bad for the brain and certainly bad for cognition over time. He's also having tinnitus and aural fullness, which is a very characteristic thing in Meniere's disease. Now, the other thing with him, though, is his overall balance function has decreased significantly over the last 6 months. We'll get into that a little bit more in just a second. So the reason we're going into the case study is if you or someone you know has Meniere's disease, you may be thinking, man, there's nothing else we can do. We're just going to have to learn to live with it. And I don't think that's true. That's the reason I do these case studies, is to provide you some other option of what can be done. It's not a guarantee, of course. Not everybody that I work with gets better, but a lot of people do. So I want to walk through this case and show you how I approach this, and I think maybe this will give you some hope, some realistic hope. Now, he is also having frequent, if not daily, diarrhea, which may or may not have anything to do with the overall Meniere's problem. Let's just jump into it. Okay, so health history. In 2009, he was diagnosed with Crohn's disease. Well, you know, for someone with Crohn's disease, what that is, that's an inflammatory bowel disease. One of the characteristic things you find in Crohn's disease is diarrhea. Sometimes it can alternate between constipation and diarrhea. Sometimes these people will get diagnosed with IBS, but he's definitely diagnosed with Crohn's disease. Now, here's what this means to me as the guy who's trying to help him get better. That is an autoimmune condition. So I already know that in this particular case of Meniere's disease, the patient has got an autoimmune history. Now, I don't yet know if that's really connected to anything else, but I'm really suspicious about it, because if you've watched my channel very long at all, you'll realize that what the research shows and what my experience shows is by far what is most commonly going on in the people with Meniere's that I see, so there's a little bit of a selection bias, is something's going on with their immune system. Now, it's not always the same thing with every person. It's not always an autoimmune condition, but now I already know that this guy has the first thing that I'm super duper interested in to find out if it's significant in his case. 2016, he had an abscess in the bowel mesentery, was hospitalized, had to take antibiotics, and had to have 3 feet of his bowel resected, so a pretty big deal. 2018, he began taking Entyvio, which is it's a biologic immune system medication, and says he's in remission, but he still reports all this diarrhea, which to me makes me question the assessment of, hey, I'm in remission from Crohn's. I don't think she'd be having almost daily diarrhea if that were true. Now, he says the diarrhea can be correlated with stress and sometimes diet choices. In the fall of 2018, he began having symptoms in the right ear, including tinnitus and feeling sort of, dizzy and equilibrium off after some loud noises at a concert. Now, that by itself doesn't make you think that he has Meniere's disease, but we do know that now we're having what we call these auditory and vestibular symptoms. So let's see how they develop. Well, just a few months later in the spring, then he had the onset of rotational vertigo. An ENT diagnosed him clinically at that time with Meniere's disease based on his symptoms and prescribed meclizine. Now, meclizine is not a medication that's going to fix anything. Meclizine is a vestibular sedative. So when he has these episodes, taking the meclizine might make them less debilitating or make him feel less terrible while the episode's going on, but it's not going to fix anything. He used to have problems from the fall to the spring. Now that makes you think, well, that could be some sort of seasonal allergies, something in the air. It's still his immune system though. But in the last 6 months before he saw me, he's having symptoms daily rather than seasonally. So we know his condition's getting worse, okay? So that's really important for me, looking at kind of the tempo and the pacing of his symptoms and his condition. And one of the reasons that matters is, if I start treating him and all of a sudden those symptoms go away, I go, okay, we might have done something very positive. But when a Meniere's patient has symptoms that are not very frequent, you're going to take a longer amount of time before you can really make any conclusions about, okay, do we think we're doing a good job with his Meniere's? The week before Christmas of 2023, his writer's symptoms increased significantly. He had a huge flare-up. He was having constant tinnitus and having vertigo attacks up to 2 times per week. He saw a different ENT who prescribed a diuretic. And again, this is all kind of first-line stuff that the ENTs do. And there's not great evidence that diuretics really do that much. You're always going to get prescribed one, almost certainly. Usually going to get prescribed some sort of steroids. And, we can talk about the physiology of Meniere's. I do that in some other videos. But just know that the diuretic is a real common thing. The idea is to reduce fluid and thus reduce fluid pressure in the inner ear because there's no place for that pressure to go. So the idea is that if there's increased fluid production, there's going to be increased pressure, there's no place for it to go, and it's going to start pressing on things and giving episodic vertigo and tinnitus and hearing loss. But the question is, for me, is why is there increased fluid production? Why is there increased pressure? And the answer very often is there's something going on with their immune system. Not always primarily in the inner ear, but there's something going on somewhere. Also prescribed beta-histine. Now that's kind of a inner ear vasodilator. That may or may not help. It's certainly not guaranteed. Now he was prescribed a low sodium diet, which was the right thing to do. Low sodium, the reason that helps again is to reduce fluid pressure because wherever sodium goes, water is going to go. All right? So it's kind of a low-hanging fruit to prescribe a low sodium diet. It's one of the very first things I'll always make sure my patients are doing when they come in. Are you on a low sodium diet? And if they're not, we're immediately going to put them on it because it's such a low hanging fruit. Now, for some people, that can make a very big change. Now, one of the other reasons that low sodium can help is sodium beyond a certain threshold, which is individualized for everyone, it's inflammatory. So is it the fluid pressure thing that's the positive benefit of low sodium, or is it the fact that you're decreasing inflammation? Could vary from person to person. That little thing, that little course of treatment that the ENT recommended has alleviated some of the pressure, which is great, but he's still having the rotational attacks. There's still something missing. Now, family history. Brother with ulcerative colitis, guess what that is? That's an inflammatory bowel disease. Grandmother with ulcerative colitis, that's an inflammatory bowel disease. It's an autoimmune condition. And this particular patient might as well just have been diagnosed with ulcerative colitis. His symptoms just differed somewhat, but basically they're the same thing, right? They're an autoimmune inflammatory bowel condition. So if I didn't know they already had Crohn's disease and all I saw was his family history, I immediately would have been super suspicious of what is going on with this guy's immune system. It's probably autoimmune because having a first-degree relative with an autoimmune condition means the odds of you having one go way up. Now, what he's taking at the time that I first saw him, he's taking Entyvio, which is this biologic medication, triamterene, HCTZ, which are the diuretics, and beta-histine, which is the vasodilator. And he was having B12 injections that were recommended subsequent to the bowel resection, which makes sense. He's taking a multivitamin, vitamin D2, not D3, and magnesium. Nothing really problematic with any of that stuff. Taking probiotics, that all makes sense. It's taking some omega-3 fatty acids, but they're pretty low potency. I think I want to point out about that is, well, I don't know if I should tell you this or not, but I will. Omega-3 fatty acids are great, and they're generally very anti-inflammatory, but if you don't take a therapeutic dose of them, they may not do anything. And he's taking I'm not going to put the name of it, but an anti-inflammatory supplement that's also pretty low potency when you look at the ingredients in it. So what's his diet like when I first see him? Well, it is gluten-free, fantastic, because if you watch my videos at all, pretty much gluten across the board is something we're going to reduce and get rid of in a Meniere's patient to find out if it helps, because it's generally going to be anti-inflammatory. Now, he does eat cheese, which is dairy, and I don't know if you guys heard me talk about this before, but if you give up gluten but not dairy, to your immune system, it's kind of like you didn't give up gluten, and here's why. Because there's extremely strong cross-reaction between dairy and gluten. And what that means is that they look very, very similar to your immune system. And so if you have a problem with gluten and you're making, antibodies to gluten, and you give up gluten, fantastic. But the thing is, just use my hands for an example, dairy, okay, looks an awful lot like gluten, does it, right? Now, it's not the same thing, but it looks enough like it that you get cross-reaction. And what that could mean is you don't really get the full benefit of going gluten-free unless you're going dairy-free at the same time. His diet is not low sodium, even though that was prescribed to him, so we're going to fix that. So some other triggers I want to point out that we found out in his case is that stress, like emotional stress, certainly seems to trigger things. Why? because stress is inflammatory. It just is. Like, we know that. That's a well-established fact. So stress being a trigger of an attack is not some sort of like, oh, it's in your head emotional thing. That's a real physiological thing. Stress is inflammatory. Again, he's having frequent, if not daily, diarrhea. I don't think his Crohn's is in remission based on that symptom alone. And he does have symptoms of what I call low HPA axis tone. We're not really going to get into that. I just wanted to mention it. The significance of that, we're just going to skip it for now. So what do we know? So in this gentleman who's 40 years old, diagnosed with Meniere's, diagnosed with Crohn's disease, has an autoimmune family history, he's having some pretty frequent symptoms. It's in the right ear. He's got autoimmune disease for sure. Very little lab testing, if any, so far. Like, really, no one's investigated his immune system at all, which is not that surprising. I mean, you can take the stuff I'm going to talk to you guys and share it with an ENT, and they're probably going to go, oh, that's interesting. But they're really not going to do anything different, which is sad, but, you know, they have their own limitations, I guess. So what I'm going to think about when I'm looking at this guy is, okay, I have 4 kind of priorities of things I look at. And for me, number 1, for all the patients I see, whether the Meniere's or not, is the number 1 priority above everything is what is going on with this person's immune system, AKA what is their immunophenotype, okay? And we'll get into what that means. Now, I already know he's got an autoimmune disease, so that's why this jumps all the way to the top of the list, right? He's got the thing I am most interested in for any patient, is what is going on with his immune system. Yes, he's got GI symptoms, but as you'll see, there's a reason why we're focusing on this. All right, so we did some blood work on him. Not that much showed up. So this is what I would call regular blood work, okay? It's not exotic, it's not sexy, not like this other stuff I'm going to show you guys in a second. It's regular blood work. Now, why does it matter though? Well, it matters just because, you know, me being, you know, his physician, you know, his doctor, I need to look at his overall health. I don't want to get too focused, you know, hyper-focused on just the ear or whatever. And so here's what we found. His ferritin is a 56. Now, why do we care about that? Well, ferritin is your best test for iron, okay? Ferritin reflects 22% of your body's iron, and an adult male should be nowhere below 100, nowhere. Now, I know you guys can see the range there, right? 300 to 30 to 400. That's an incredibly wide range that really makes no physiological sense. I can just tell you from, you know, 20 plus years of doing this, a healthy male should not be anywhere near 100 or below, and he's well below that. So why is that happening? Well, it could be happening most likely because of malabsorption, because he's eating iron. He's not a vegan or a vegetarian. And so what that usually means is we got something impairing iron absorption in the GI tract. And we're going to have to fix this just for his overall health anyway. I mean, does low iron really connect to the Meniere symptoms? No, but you do need ferritin to make thyroid hormones. Excuse me, you need iron to make thyroid hormones. You need iron to make ATP. You need iron to make hemoglobin. You need iron to make neurotransmitters. So we're going to fix this anyway. Now, homocysteine is a substance that we've all got, and it's not a big deal as long as you aren't recycling it. Now, his is not crazy, but you know, I really don't like to see anybody above an 8 or a 9. So why does that matter? Well, homocysteine is very inflammatory once it starts to pile up. It's very, it promotes oxidative stress is the terminology we use. And it's very bad for your cardiovascular system, your cerebrovascular system, and it's a potential source of inflammation, okay? Now, the main nutrients you use to recycle that are vitamin B12 and folic acid, but without going into his B12 and folic acid levels were normal, yet his homocysteine is still high. There's a few other nutrients that could be mixed into that. I'm just pointing this out. Now, the last thing that showed up on his regular blood work was his vitamin D, which again is not terrible, you know. 52 is not a bad level, but for someone that I know has an autoimmune problem, right, and he has Crohn's disease, right, I want that to be at least 70. Now, that's not some crazy toxic level, right, it just isn't, but it's more, I feel better when someone's got their vitamin D in the 70s or 80s, because vitamin D is anti-inflammatory. Vitamin D is regulatory to the immune system. Now, please, though, let me just say something. Please don't run out and just start taking vitamin D because I said that. You don't know what your baseline level is. You don't know how much you should be taking. So please don't do that. You definitely need to be working with someone that can guide you like I did with this gentleman. So what do we know? Ferritin's too low, homocysteine's too high, vitamin D too low, okay? Now, the more advanced testing we did is we looked at this panel. So this is a multiple tissue antibody panel. So remember, when you're looking for autoimmune problems, you check for, I'll just show you, antibodies. Antibodies are like little post-it notes that your immune system makes to stick onto something. And I'll just touch the screen here. And having some level of antibodies, as you see here in the green, that's normal, okay? But when you have well, I'll just show you. So when you have a big stack of antibodies like you see there, that is not normal, okay? Now, why are we doing this panel in this gentleman's case? Well, because I already know he's got one autoimmune problem. And what we all know is that once you have one autoimmune problem, it becomes much easier to get a second and a third and a fourth. And this is a way of trying to find out, has his autoimmune problem expanded, okay? Now, all those tissues you see on the left over there, we've got stomach and intestines and heart and all that kind of stuff. Interestingly, these guys right here, which are kind of inflammatory bowel markers, those were normal. So maybe his, his Crohn's is in remission as far as antibodies go, but the diarrhea still bothers me. That could be, a consequence of having 3 feet of his bowel resected, but nonetheless. The first thing that showed up here, I'm going to walk you guys through this. He had alpha-myosin antibodies. So what is that? Alpha-myosin is a protein you find primarily in heart muscle. And the thing I have to tell you is this. That antibody being elevated does not mean he has an autoimmune heart problem, okay? When antibodies show up like this, they can indicate one of a couple scenarios. Number one is a preclinical scenario. And that's where, yeah, you've got the antibodies, but you don't really have any symptoms that we would associate with that specific antibody yet, okay? So for example, with this one, alpha-myosin, what that predisposes you to is dilated cardiomyopathy. And you can find that in a lot of different autoimmune cases, but he doesn't really have anything that would make me think, oh, this guy has got early dilated cardiomyopathy. So this is probably preclinical, okay? Now, the other scenario that it could show you when antibodies are elevated is a subclinical situation. That's just when you do have symptoms that we can associate with that antibody, but you don't meet all the criteria for a named autoimmune condition, right? And then the third thing it could show you is just overt autoimmune disease, right? Like, yeah, you have all the criteria, right? You meet it all, okay? So the first thing he has is alpha-myosin. Now, here's the other thing I want to point out about this test. One of the reasons we do this test is to get a kind of lay of the land, right? The other reason we do, like what's the state of the union of his immune system? The other reason we do it is because it can actually tell us what foods he should probably avoid. Now, this is not a food sensitivity test because IgG food sensitivity testing is wildly unreliable. I don't find it helpful at all. But if we know what tissue antibodies he has elevated, we can work backwards. Because there's a thing that happens in the immune system called cross-reaction. And that's when the antibodies for one thing can stick onto another thing. And it makes the immune system attack both things. So it's really important to know what antibodies he has. And I'll go through that in just a second. Because if you eat the foods that are known cross-reactors with the tissue antibodies, high chance you're going to make the whole situation worse, okay? Now, the next thing that showed up on him was collagen complex antibodies. Well, collagen's in darn near everything. It's in your tendons, your ligaments, your muscles. It's even in some of these structures in the inner ear have collagen in them. And people that get collagen complex antibodies, classically what they end up with are arthritic conditions. But it's an autoimmune based arthritis. It's not like a wear and tear, osteoarthritis. It's an immune-based arthritis, okay? And then the last thing that showed up on him was this stuff called alpha-tubulin and beta-tubulin. Now, the thing about this is this can show up in a lot of things. It can show up in rheumatoid arthritis. It can show up in toxin exposure. It can show up in Hashimoto's, which is an autoimmune thyroid condition. It can often be stimulated by a strep infection. Bacteria, viral infections love to cross-react as well, not just foods. I want you guys to notice something. Or maybe you won't notice it, but I'll just tell you. None of these antibodies on here that I'm showing you, none of those are thought of as inner ear antibodies. Now, why does that matter? Well, it's because inner ear autoimmune conditions are pretty rare. But what's not rare is this stuff here that I'm showing you. And remember, what I'm trying to find out is what is going on with this patient's immune system, okay? And just remember that your immune system is not confined to one little compartment of your body. What is not uncommon is having one of these problems outside the ear, and the inflammatory consequences of that autoimmune problem circulate throughout the body, and that is what's destabilizing his inner ear function. That's why we're doing that test on him, right? We're trying to get an idea of half of the answer, what's going on with his immune system. So let's talk about the cross-reactive foods for a second. Actually, there's one other antibody. He did have elevated glutamic acid decarboxylase antibodies. Now, what do we care about those? Well, GAD or GAD65 antibodies, those do show up in type 1 diabetes. They also show up in neurological autoimmunity as well, and he shouldn't have them, right? He shouldn't have them. So let's talk about the food cross-reactors. So for alpha-myosin, here's the food cross-reactors: wheat, corn, and egg yolk. Okay? Means if he eats those foods, it's a high chance of kind of throwing fuel on the fire and making his immune system attack the alpha-myosin more, which we don't want. Okay? With collagen complex, no one likes to hear this, especially if you're a meat eater. Beef, chicken, pork, goat, beef gelatin, those are all cross-reactors with human collagen complex. And I'll just tell you guys, as of right now, which is August 2025, I'm seeing a lot more Meniere's patients that have collagen complex antibodies. Now, I don't know if that's significant yet. I can't, I don't really have enough of a statistical power, but I am seeing it more often than I used to. And then the last one down, this third one down here, tubulin, we don't know of any cross-reactors with that, okay? But with glutamic acid decarboxylase, check this out. Look at all these grains: milk, wheat, buckwheat, amaranth, rice, corn, yeast, which is Saccharomyces cerevisiae, like baker's yeast, brewer's yeast, nutritional yeast, potato, like white potato, quinoa, oats. Those are all the known cross-reactors. Now, the worst are the first kind of four you see there: milk, wheat, buckwheat, amaranth, but the rest of them do cross-react. So that's the information I get out of this multiple tissue antibody panel. I get to find out, hey, this guy has some other autoimmune stuff going on. Now, whether it's preclinical or subclinical, his immune system is identifying these things, and I think it's significant. It lets me know that his immune system certainly is not just Crohn's, right? There's some other things his immune system is thinking about attacking. Now, the other half of the question, what's going on with this guy's immune system, the other thing is this panel. Okay, so what this is a lymphocyte map. Now, the fancy word for this that you'll see right here is comprehensive lymphocyte immunophenotyping. So what this is basically, it's like getting your immune system fingerprinted, all right? Phenotype means what does something look like. Immunophenotype means what does this guy's immune system look like? If I pop the hood and I look in here, what is it doing? What can it tell me? Okay, and how we find that out is we look at T cells, lots of types of T cells. We look at B cells, natural killer cells, and I'm not going to run through this line by line. I'm just going to point out a few things. So first thing you'll notice is as his B cell percent is up, and that's throwing off his T cell B cell ratio. And that's sort of non-specific, it's not really pointing me to anything, but I'm going to use some of this information in a second to figure out what am I going to do with this guy, right? How am I going to treat him to try to help him? The next thing you'll see is that his percent T helper 1 is a little bit low, but this TH1 TH2 ratio is really not that out of whack. And that's interesting because when the T helper 1 T helper 2 ratio is really not out of whack, that kind of argues against autoimmune tone, let's call it, being really abnormal, right? But you see here, T helper 17. Well, T helper 17 is definitely elevated. And here's why that matters. T helper 17 cells are the effector cells that do damage that the immune system wants to do, whether it's autoimmune or non-autoimmune, right? It could just be inflammatory, meaning there's not antibodies, running the show. But T helper 17, that's some nasty stuff to have elevated. And one thing I know, you see how his regulatory T cells are normal? That's not supposed to be like that. Now, what should happen when his Th17 cells are elevating, his regulatory T cells should be elevating at the same time, because guess what they do? They regulate. They counteract these T helper 17. So I know that other kind of check and balance is not working in him, and that's a therapeutic opportunity. Now, these guys down here, all these natural killer cells, these guys elevate in a couple situations. They elevate if there's viral infections. They can elevate, if there's mold, they can elevate as part of the immune system trying to regulate itself. So when I look at this guy's phenotype, right, what I look at is that and I say, hey, his Th1, Th2 ratio is normal. So for me, that kind of argues against this being an active autoimmune problem. But his Th17 is high and his Tregs aren't high enough. As NK cells are high, maybe that's, neuroautoimmune, maybe that's post-infectious, but I look at it and I say, this guy's got an inflammation problem. That's how I'm looking at it, right? He's got a couple different antibodies that are definitely high. Those are preclinical. There's probably foods provoking those, the cross reactors. So what are we going to do? Okay. So the treatment plan that I decided to come up with this gentleman is as follows. Number one, we're going to improve his iron and vitamin A. We're going to supplement those. And then I'm going to put on what I call a short-term anti-inflammatory repair diet. Now, you guys know I'm not going to tell you exactly what that is because it may not be appropriate for your case. But what we're going to make sure he does is he avoid all those cross reactors I pointed out, right? All those cross reactors, right? The beef, chicken, pork, goat, the wheat, milk. He's going to avoid all that stuff because I need to know, is it going to make a difference? Okay. One of them was no grains. And then I'm going to use an anti-inflammatory immune regulatory supplement protocol, which, based on my clinical experience and some particulars of his case, I think is going to have the best chance of helping him. Again, I'm not going to tell you exactly what that is because I don't want you treating yourself, right? This stuff is too complicated and it's way too easy to mess yourself up. So make sure you're working with someone that can do what we're talking about here. So what happens is 30 days later, here's what he reports. He says the fullness and the ear pressure are essentially zero. Now, the week before he talked to me here on the follow-up, he had a little sinus pressure that did cause a little bit of a flare-up. That makes sense, right? Increased pressure intracranially could increase his pressure a little bit, right? His tinnitus has decreased in intensity a lot. Bowel movements have decreased in frequency and have increased in their consistency and form. So what does that tell me? What that's telling me, either the diet or the supplement protocol or both are affecting that GI tract involvement, and it's definitely affecting the pressure. So we're probably right about thinking of this guy's case as inflammatory, right? We're probably right. And he's lost about 12 pounds. Now, we're not starving him, just so you guys know. That repair diet, that anti-inflammatory repair diet, it's not about restricting calories. It's about restricting where you're getting them from, right? But men very often lose weight on that diet because it's very highly anti-inflammatory. And once you're de-inflamed, you can burn fat much more efficiently. He's also had no vertigo at all. Okay, so he's had a full 30 days of no vertigo episodes at all, which is a big change for him. Right? So now that we know that he's doing pretty well, what do we do now, right? Well, he's going to continue the diet as is. We're not going to change that yet, right? Like, it would make no sense to just change the diet and say, hey, let's go back and add back foods. Why? Because he had such a positive response. It makes sense for him to stay off of those foods longer so that if and when we reintroduce any of them, there's a lower opportunity or lower odds that he would react to them. We'll get to that later. All right, and we're going to continue that protocol, the supplement protocol. In about 30 days, we're going to recheck his ferritin, his homocysteine, and vitamin D. The ferritin and D, because we're giving him iron, we're giving him D. The homocysteine, I'm not giving him things specifically for that, but I do want to see if that goes down. All right, so after 60 days of treatment, again, ear fullness and pressure are essentially zero, right? Completely resolved. Tinnitus has gone down 67% based on what he says, and he hasn't used his hearing aid in about 3 weeks. So what does that mean? That means his hearing has increased. So some of the thought to be permanent hearing loss has improved. Now, that's surprising to a lot of patients. It can be surprising to ENTs as well. But what it tells you is that the pressure in his ear had not been so bad for so long that it killed off the hair cells in his cochlea. They were able to be rescued, which is fantastic, right? Good stuff. And again, the bowel movement, bowel frequency, that's still improved. So there's definitely been a marked change with that. And again, no vertigo episodes. So now we're going on 2 months with no vertigo episodes at all. Now, he did have one instance. He was turning over in bed to the right and had a few moments of some rotational vertigo. Now, what that sounds like is it sounds like benign paroxysmal positional vertigo, or BPPV. But it may not be in his case. What can happen is when you have a vestibular system that's been unbalanced for so long, and then you do something like we're doing, and it starts to normalize normalize the function of the bad side. When the bad side's been bad for a while, the vestibular system can take a little while to recalibrate. And so I'm wondering if that's not what's going on here, right? I gave him some home, for lack of a better term, some home recalibration exercises just to kind of help that process along. So again, after 60 days, the retest results shows vitamin D is 109. That's a little higher than we wanted, right? Now, is he going to die? Is his liver going to dissolve? No, but that's a little bit high, so I'm going to need him to reduce his vitamin D a little bit. Homocysteine's gone down 3 points. That's without giving him any B12 or folic acid. So part of what we're doing by decreasing inflammation and some of the other stuff in the protocol is addressing the homocysteine. So I don't need to do anything more for that. Now his ferritin, which is iron, has gone up 10 points. Now, is that, a world record? No, but it did go up. So the fact that it did go up means we're going to continue supplementing. So what now? Well, so he told me at that time he's planning on following these recommendations exactly for about a calendar year, okay? He is extremely pleased with his progress so far. I mean, I understand why, right? No vertigo episodes, hearing. He's got some of his hearing loss is improved, that's good stuff. And he says it's wonderful to know that a storm is coming and have his ear not be affected at all. Now, what he's referring to is something I've talked about in other videos. A lot of Meniere's patients, I go on right now, are very sensitive to changes in barometric pressure. Now, what that means is like particularly when a storm front comes through, barometric pressure drops. And so what that literally means is that you, from the inside out, can expand a little bit. And in some people, that increased pressure is enough to trigger symptoms. What that usually means to me is that there is still some inflammation going on that hasn't been addressed if that's happening in someone. And it also may mean that their kind of built-in pressure relief system, and there is one in their inner ear, is not functioning very correctly, or not functioning very well. But his is. So we're going to continue the diet, we're going to continue the supplement protocol. After 5 months, so this is after 5 months of treatment, ear fullness pressure continued to be basically 0. And he says, good morning, he sent me an email. I haven't used my hearing aid for quite some time now. I have some residual tinnitus, but I attribute that more to some foolish decisions regarding loud equipment and a lack of hearing protection. So big changes in his auditory symptoms. Bowel movement's still looking great. No vertigo episodes for the last 5 months. Okay, so this is what I told you at the beginning. When someone's having fairly frequent symptoms and then we start treatment and those symptoms go away very rapidly and they stay gone, makes me feel pretty good about it. I'm feeling pretty good about this guy's long-term prognosis. So after 5 months of treatment, he said that kind of wooziness he was feeling I talked about a second ago where he was rolling over in bed, completely gone. Now, maybe that's because of the recalibration exercises I gave him. Maybe it was just, chance. We don't know. Now, this is really cool. I like this part. This is one of the reasons why I do this. He can now wrestle with his kids comfortably, right? He can jump up, he can contort his body, he can, do fun things and not be guarded. And he says it's very freeing, right? Because imagine, you're a young guy, you've got kids, your kids want to roughhouse and wrestle and you can't do it because you're afraid, right? You're afraid it's going to trigger an episode or it's going to give you nausea. And that's the thing about Meniere's. People that have Meniere's disease typically don't have a very good quality of life. I made a video specifically about this. And that's kind of one of the things that I am trying to do when I work with these people is, not just make their symptoms better, but make their quality of life better, right? That's to me is really, really important and worth doing. So he's still taking Entyvio at this time. He did try to reintroduce egg yolks, and that did not go well. He said, the couple times he tried it using the guidelines I gave him, straight to the bathroom, right? Did not work well at all. Very adverse reaction, and he is now wondering if that reaction to eggs might not be connected to this whole history of Crohn's disease that he's had. And yeah, it's possible, for sure. It's definitely possible. So what now? Well, remember, he said he wanted to just follow these instructions and recommendations for a year, so we're going to continue this. Now, he did want to reintroduce rice, and I said, hey, give it a shot, see how it goes. We're going to continue the same protocol. And after 11 months of treatment, right, almost a full year now, still having no vertigo episodes. Hasn't any vertigo episodes for 11 months. Ear pressure fullness, basically 0. Rarely has to use the hearing aid, if at all. Bowel movements are looking great. Maybe going to be stopping the Entyvio because he did say that the last couple injections he had, he didn't feel great. And maybe that he doesn't need it. I mean, just to be honest, it just may be that he does not need that anymore. Now, Meniere's disease can fluctuate, okay? And so, you know, I'm not going to run to the top of the hills and say, oh my gosh, this guy's cured, because that's not what I do. But I'm showing you this to let you know that here's a guy that was having really bad symptoms, right? He'd done some sort of the first line treatments, and his symptoms weren't getting better. And what we were able to do, the royal we, what I was able to do, I hate saying I did this or I did that, but what we did is worked up and said, hey, this guy makes me think of his immune system. Let's evaluate his immune system and see what we find. And now, was there glaring evidence of a lot of immune system abnormalities? Depends on your perspective. I've seen, you know, hundreds of different phenotypes on that testing, but his said, that looks inflammatory to me. And his history said his immune system's abnormal. So we treated it like that. And the treatment kind of is the test ultimately, right? Like, all that testing is great, but it's not until you treat someone and find out how they respond that you really find out if you're on the right track or not. And I think we are with this gentleman, because hearing loss has improved. He's having no vertigo episodes. And I'm showing you this because, number one, I mean, not because I think I'm smart, but to show you that this is possible in a large number of patients. Now, not everybody. I mean, I certainly have people that we do workups on and we don't find anything. I have people we do workups on, looks like there's something, we treat them and nothing happens. But the thing is, we're not going to know what's possible unless we do the workup and do the treatment, right? We're not going to be able to know what's possible. So I hope you guys found that very helpful. And again, if you're, you know, suffering with Meniere's disease, or your loved one is, please don't try to treat yourself. It is way too difficult. Make sure you're working with someone that knows these things that we talked about. And I'll be posting more cases, and hope you guys find that helpful. We'll see you later. Have a good one.